Welcome to the M. Bovis webinar. I'm Jeannie Fong, the Program Manager at the Curry Center. We have over 570 participants joining us from across the U.S. Today's session is being recorded. We will archive these trainings on our website in the near future. You all have been placed on mute in order to preserve the quality of the recording, and for this reason, we ask that you reserve all questions and comments for the Q&A period. Now it's my pleasure to introduce our facilitator, Ann Raftery. Ann is the Associate Medical Director and Nurse Consultant at the CIPC. Ann?
Thank you, Jeannie. This webinar is produced by the Curry International TB Center, which is part of the University of California, San Francisco, and located in Oakland, California. The Curry Center is one of 5 regional tuberculosis training and medical consultation centers in the U.S., and we cover the states in the western region, as you can see indicated on the map here. This project was funded by the Centers for Disease Control and Prevention's Cooperative Agreement and is a project of the University of California, San Francisco. The Curry International Tuberculosis Center is accredited by the ACCME to provide continuing medical education for physicians, and the center is also an approved provider of continuing education by the California State Board of Registered Nurses. This webinar is approved for a total of 1.5 continuing education contact hours. To receive your continuing education contact hours, you must have registered for the webinar, participated in the entire training, and complete the online evaluation. The website for the evaluation will be emailed to all registered course participants immediately following the webinar. All of today's faculty have signed a declaration of disclosure and have indicated that they have nothing to disclose. And now it's my pleasure to introduce you to our faculty for today's webinar. Dr. Philip Lebeau is the Director of the Division of TB Elimination at the Centers for Disease Control and Prevention. Prior to his current appointment, he served as Associate Director for Science for the division and held previous positions as Chief of the Medical Consultation Team and as Field Medical Officer in the San Diego County TB Control Program. Dr. Lebeau has published several papers and book chapters on human tuberculosis caused by Mycobacterium Bovis. Dr. Neha Shah is a Field Medical Officer with the Centers for Disease Control and Prevention assigned to the California Department of Public Health. Prior to coming to California, she was the TB Controller in Chicago and did her EIS training with the Global AIDS Project. She is part of the MDR TB Consult Service at the State of California TB Control Branch and is California's point person for issues pertaining to the new treatment regimen for latent TB infection, affectionately referred to as 3HP. Dr. Jennifer Flood is the Chief of the Tuberculosis Control Branch at the California Department of Public Health. She has served as the President of the National Tuberculosis Controllers Association and has cared for tuberculosis patients at San Francisco's TB Clinic and Hospital for over 2 decades. Dr. Flood is an infectious disease physician and Associate Clinical Professor of Medicine at the University of California, San Francisco. In today's program, you'll be hearing from Dr. Lebeau about tuberculosis in humans caused by M. bovis, how it's identified, the epidemiology, and issues pertaining to transmission. Dr. Shah will then present an overview of the epidemiology, risk factors, and treatment outcomes associated with Mycobacterium bovis in California, as well as recommendations for treatment and prevention. Then we'll hear from Dr. Flood, who has several very interesting cases to present, after these 3 presentations, we'll open the lines to receive questions from the audience. So please make note of any questions that you have as you listen to each one of these presentations. These are the learning objectives for this course, and while I'm reviewing the learning objectives, I'll ask our program manager, Jeannie Fong, to please pull up the slides for our first speaker. And Dr. could have you unmute your phone.
Yes, I've unmuted my phone.
Okay, great. So upon completing this training, participants will be able to understand the risk factors for acquiring M. bovis infection and disease in order to more effectively make a diagnosis, understand the M. bovis diagnostic methods in order to improve patient outcomes, and state at least 3 best practices for the management and treatment of M. bovis so that infection and disease progression can be prevented. And now, let me turn things over to our first speaker, Dr. Phil LeBeau.
Thank you, and good morning. As shown on my title slide, I'm going to be talking about M. bovis in terms of identification, U.S. and global epidemiology, and transmission. So, Mycobacterium tuberculosis complex is the term given to a group of bacteria, and there are a number of species within the Mycobacterium tuberculosis complex. The 2 most important are Mycobacterium tuberculosis, which is the usual cause of tuberculosis in humans, and then Mycobacterium bovis, which also causes tuberculosis in humans, but is particularly an issue related to agriculture and infection in cattle, but can actually infect a large number of mammals, as I'll show in a later slide. Within Mycobacterium bovis is also the BCG strain. BCG, as many of you may be familiar with, is a vaccination that's used in many parts of the world. It is effective in preventing dissemination and meningitis in children. It is not generally effective in preventing TB overall, but can prevent more serious forms of disease, particularly in children. And that was developed by taking Mycobacterium bovis and attenuating it to develop the vaccine. And then there are a number of other species which I list in the slide, some of which have been found to cause disease in humans, but are really pretty rare, and so are not that significant. So again, the most common causes of TB in humans, number 1 is clearly M. tuberculosis in the United States. Causes about 98% of TB cases. And next on the list is M. bovis, which is probably about 1.5%, and then everything else combined of those organisms I listed is just a fraction of 1%. But there's also geographic variation, so it is not evenly distributed throughout the country, and particularly some areas around the border, and San Diego is probably the best example where much has been published. It is more common. In developing countries, not all that much is known. It is very likely that M. bovis may account for a higher percentage of disease where the organism is found in cattle and pasteurization is not widely used. And there are some small reports from parts of Africa, but it's really not been well studied because most of the countries do not use culture or genetic testing methods that allow you to differentiate between Mycobacterium tuberculosis and Mycobacterium bovis. So clinically, basically you cannot really tell the difference between Mycobacterium bovis and M. tuberculosis. They can look the same on chest x-ray, symptoms are basically the same. Really, in order to be sure which organism is causing the disease, you need to do appropriate laboratory testing so that you can actually isolate and identify the organism. And that can be done, as I'll talk about, either by doing culture and doing biochemical tests, which is the older way of doing it, but the more modern way is to use genetic testing to differentiate between the two. Now, BCG, which is used, as I mentioned previously, for vaccination in parts of the world where TB is common, is also used as a treatment for bladder cancer. And occasionally, the BCG, which is a live vaccine, can disseminate throughout the body and cause illness. That generally happens when people who are immunosuppressed. Of course, people with bladder cancer have some degree of immunosuppression from their cancer, and it can be more severe if they're getting other types of treatment. But even so, even though this does happen, it is not all that common. So how do we tell the difference in the laboratory? Well, there are a number of characteristics in terms of culture and biochemical testing. M. bovis grows better on pyruvate-containing media. There's less cord formation when you look at the colonies. It is almost universally resistant to pyrazinamide, but is sensitive to another drug used in, not that's used to treat people, but is used in culture to differentiate these organisms, which is called TCH. And also there are two other biochemical tests, niacin test, in which it's, M. bovis is negative on that test, and the nitrate test, which is also negative. And before the advent of molecular testing, this was the way it was done with these biochemical tests. That's how the M. tuberculosis was differentiated from M. bovis. Now, though, we generally use genetic tests. And the first one that you can look at is the PNCA gene. And
you are no longer muted.
Because M. bovis is resistant to pyrazinamide almost universally, you will see a mutation in the PNC gene, which is consistent with pyrazinamide resistance. Next, the standard methods that we use for genotyping in the United States, spaligotyping, combination of spaligotyping and the Miru VNTR methods, will show that there are different spacers and repeated sequences between M. bovis and M. tuberculosis. So that is allowed us, actually, because we have very high rates of coverage of genotyping for isolates, to get some idea now on how much M. bovis there is in the United States by just looking at the genotyping that we typically do. M. bovis and M. tuberculosis both evolved from a common ancestor, and over time, M. bovis appears to be actually the more recent split on that evolutionary tree, and has lost certain genes that M. tuberculosis has. So another way that you can differentiate is you can do something called gene deletion analysis, looking for seeing that M. bovis isolates will have lost certain genes. You can do whole genome sequencing, and in general, really the genetic methods are what we use now, and they are the best, and they also are best for differentiating between M. bovis strains that cause disease and those that are due to BCG vaccination or are found in are instilled for treatment for bladder cancer. So M. bovis actually has been found to infect many primates. Cattle are the ones is the most commonly talked about because it has major agricultural implications, and that's in fact where it was first isolated, and the name is derived from the fact that it was found in cattle. Humans and non-human primates can be infected, and then I've listed a whole another group of various mammals, from goats, sheep, cats, dogs, pigs, etc., common mammals that also can be infected by M. bovis. So I'm going to briefly review some of the history. So many of you probably know that Robert Koch was the one who discovered that M. tuberculosis causes TB disease in humans, and initially people thought it was the same species that caused disease in cattle, but actually in 1898 Theobald Smith identified that in fact there were two different species. M. bovis was the one that typically infected cattle, and M. tuberculosis was the one that more commonly infected humans. And this resulted in a number of years later in the British Royal Commission doing extensive research, and what they found was that cow's milk, which was contaminated with M. bovis, could cause particularly extrapulmonary TB in people. And especially there was a risk of cervical lymphadenitis in children who drank cow's milk. In the United States and other countries, based on these findings, started to implement various programs, including compulsory pasteurization of milk, and then there was a program for trying to eradicate bovine TB. That generally was based on doing whole herd testing and culling of cattle that were reacted to the caudal fold test, which is a type of skin test for cattle. And in fact, prior to the widespread use of pasteurization and the eradication program in cattle, it was actually estimated that perhaps 10 to 30% of human TB cases were caused by Mycobacterium bovis. So, in fact, there was a time when it was much more common in people in the United States and other developed countries. So, moving on to current disease epidemiology, first I'm going to talk a little bit about cattle. So, not all parts of the world have strong eradication programs for cattle, and a lot of parts of the world also don't practice universal pasteurization. And on these slides, which may be a little bit difficult to see, but I just want to illustrate that places like Africa, South America, and the next slide, Asia, that if you look at these maps, particularly the lighter red and dark red colors, the light red represents sporadic findings of the disease in cattle, and the darker red is what's called enzoonotic Mycobacterium bovis, which is basically equivalent to a disease being endemic in people. So that the darker red is actually where it may be fairly common in cattle herds. And as you can see, it's still found in many parts of Africa, South America, and on this slide, Asia. What about the United States? Well, the last data that I could find that were publicly available showed that 48 states are considered cattle TB free, which means they can't find any evidence of TB in cattle. There are two exceptions. One is Michigan, and one has been California. Now, the Michigan issue is pretty well understood in that they have a persistent problem with Mycobacterium bovis in deer. And there seems to be an infection from these deer going back into the cattle. In the case of California, where there's occasionally been cases found in cattle, it's really not so clear why those problems are occurring. One possibility could be importation of cattle from other places where M. bovis is more common. So what about the human burden worldwide? It's really not very well known, mainly because poor countries which have the high burden for TB still largely rely on AFB smear for diagnosis, and they don't perform cultures and they don't do genetic testing. So without doing culture genetic testing, you really can't differentiate it between M. bovis and M. tuberculosis. Even a lot of industrialized countries may do culture, but will stop at the identification at the M. tuberculosis complex level and not do the additional testing which would be needed to differentiate between M. tuberculosis and M. bovis. Now, with the increased use of genotyping, that's changed. If countries like the United States and a number of countries in Europe where genotyping is very common and almost universal for their TB cases, with those results, you can tell whether the isolate is M. bovis or M. tuberculosis. So, focusing in on North America, again, the disease, especially in the U.S. and Canada, is very rare due to pasteurization and the eradication programs in cattle. Overall, for most industrialized countries, M. bovis probably accounts for 1% or less of cases. And I said before, there's some specific areas where it's higher. Mexico tends to have more, though. For one thing, they have more of an issue with M. bovis in cattle. One report found that 17% of the cattle and meat processing plants were infected with M. bovis. Up to 30% of their milk is not pasteurized, and so the percent of human TB cases due to M. bovis, while not known, is likely to be higher than for the U.S. and Canada. And it also impacts the United States. If you look at a study that we did at CDC looking at human Mycobacterium bovis in the United States from 1995 to 2005, What we found was that about 1.7% of TB cases were caused by M. bovis based on genotyping results. Of those, almost 90% occurred in Hispanic persons and 62% were born in Mexico. There were also tended to be occurring in younger persons, so 19% of the M. bovis cases were aged less than 15 years old, compared to only 2% for M. tuberculosis. Extrapulmonary disease was much more common, 65%, and there was actually an increased prevalence of HIV, 26% for these M. bovis cases. So now that we have almost universal genotyping, we have started in the annual surveillance report to give the number of M. bovis cases that we find based on genotyping results. And this was this table I took from the most recent surveillance report, which had genotyping information from the latest year was 2012. And of the approximately 7,100 isolates that we had genotyping results on, what we found was that there were 121 total cases of M. bovis in the year of 2012. About 75% of them occurred in foreign-born persons and only about 25% in U.S.-born persons, which was consistent with what we had seen before, which was largely, again, probably from persons born in Mexico particularly, and even among the U.S.-born cases, most have been occurring in Hispanic individuals. So finally, I'm going to talk about transmission. So the most common route of transmission is thought to be foodborne through ingestion of contaminated unpasteurized dairy products. But airborne transmission can occur, and it's the same as occurs for M. tuberculosis. You can also occasionally see cases of direct inoculation, where it's inoculated through the skin. This used to occur in slaughterhouses while they were cutting up the meat, and if they had an infected animal, they could inoculate their skin if they cut themselves while cutting up the meat, and that was called butcher's wart when that occurred, when they got a skin infection that way. And there have been occasional case reports of hunters when they field dressing animals that were infected of also the hunter becoming infected. They could directly inoculate themselves if they cut themselves while they were field dressing the animal. What about foodborne transmission in the U.S.? Well, probably it occurs because of unpasteurized cheese consumption. So when I was in San Diego, this was fairly common that many people lived in the border region. You go to Mexico and you could get fresh cheese, which was not pasteurized. This was called, the kind of generic term for it was queso fresco. That's not the type that we get commercial in the U.S. This is brought in by individuals crossing the border for their own consumption, and for that reason it bypasses any kind of FDA or USDA regulation and inspection, and there's no requirements related to pasteurization or other methods of decontamination of the food product. And when you look at cycles of transmission, which I show in this slide, and in this diagram, there are arrows, and the thickness of the arrows suggests the probability of infection. So if you look at the top with the two cows, cattle-to-cattle transmission is probably the most common, and that's how it spread through cattle herds. And then if humans are going to get it, most likely they would get it from a cow, and there are a number of ways that could happen. One is that they could, as I mentioned, eat an unpasteurized dairy product or drink unpasteurized milk. That was probably the most common way it happened in history. But it is also possible that if you have sick cows, that it can also be transmitted through the airborne route. So that's another potential way. If you go down to human transmission, which is less common, that that will occur through the airborne route just as it occurs for M. tuberculosis. And then closing the loop, there have been some individual reports of people transmitting M. bovis or even M. tuberculosis back to cows, again, through the airborne route. But it can be more complicated, and how it can be more complicated is if you start getting wildlife reservoirs of M. tuberculosis. So here, I point to the bottom where there are deer, such as the issue in Michigan. So once you get M. bovis in a wildlife reservoir, it opens up the possibility of additional transmission back and forth between cattle. Also, it could happen from the deer to humans, and there have been some case reports of that, very rare, but it could happen. And that could happen through the aerosol route, which has happened, for example, with veterinarians taking care of elk. And then there's still the transmission routes between cattle to humans, and even the potential for human back to cattle. So with that, I'm going to conclude my part of the presentation, and I'll turn it back to our facilitator.
Thank you, Phil. That was a really interesting overview, and I think it really sets up really nicely for our next presenter, Dr. Neha Shah. Neha, if you could unmute your phone.
I am unmuted. Can you hear me?
Great, thank you. So Dr. Shaw will now be looking at the incidence of Mycobacterium bovis in California and discussing different risk factors, recommendations for treatment and prevention. So just 1 minute while we get things situated for your talk, and thank you, Dr. Shaw.
I'm hoping to build a little bit on what Phil was saying about some of the epidemiology of M. bovis and look specifically at California. I'll be presenting some epidemiologic analysis of M. bovis, and then I'll transition to treatment of M. bovis and then some recommendations for providers. What we did is we conducted, similar to what Dr. LeBoux was talking about, we conducted a retrospective review of our California TB cases from 2003 to 2011 of cases that were culture positive and had initial drug susceptibility testing for INH, rifampin, and PZA. We defined pediatric cases as less than 15 years of age, and then the M. bovis definition we were using for this analysis was that they were resistant to PZA but susceptible to INH and rifampin. This figure outlines how we arrived at our cohort for our analysis. There were about 24,000 TB cases reported between 2003 and 2011. After we went through our exclusion criteria, we found that there are about 742, or 4% of all of our cases, that were due to M. bovis. Of those 742 cases, 11% of them, or 82 cases, were in pediatrics. There was about 70%, or 519 cases, in individuals aged 15 to 64, and then about 19% of all of those cases were in individuals aged 65 and above. And we don't usually think of M. bovis cases in that age group, but we had a good proportion of them that were in that age group. M. bovis, as I mentioned, accounts for about 4% of our cases, and as Dr. LeBoux mentioned, nationally there's about 1 to 2% of cases attributed to bovis. So we have a bit of a higher proportion of our TB cases attributed to M. bovis. Though most of our bovis cases are concentrated in Southern California, we do have cases that occur across all 32 counties. This is what M. bovis looks like compared to TB. The TB case rate here shown in red has gone down significantly since 2003. Unfortunately, there has been no detectable trend in our M. bovis case rates, and they've been pretty stable, shown here in blue. And overall, the actual percentage of TB cases attributable to M. bovis has increased from 3.4% in 2003 to about 6% in 2012. A quick summary of some of the major findings of our univariate analysis. Compared to TB, M. bovis, as I mentioned, was associated with pediatric cases. We had 11% of our cases in M. bovis versus 2% of our TB cases were due to TB in our pediatric population. Additionally, Bovis was associated with being Hispanic from Mexico, and the site of disease was more likely to be extrapulmonary. When we look specifically at our pediatric cases, 87% of those were extrapulmonary, with lymph node TB being the most common. However, when you look at all of our pediatric TB meningitis cases, 16 to 20% of those are attributed to Bovis. And as you know, pediatric TB can have high mortality rates and lifelong serious complications. In addition, when we looked at some of the new reporting variables compared to TB, the M. bovis in pediatric cases, they were more likely to have a parent or guardian born in Mexico or had lived in Mexico for 2 months. So the strong connection to being from Mexico. For adults, compared to TB, Bovis was more likely to be among those who were Hispanic from Mexico, those who have diabetes, kidney failure, on immunosuppressive therapy, or be HIV positive. In terms of treatment outcomes, Bovis cases were more likely to die before treatment. And then among those that did die prior to treatment completion, the M. bovis cases were more likely to have at least one concurrent immunosuppressive condition. In summary, just from this analysis, California has a higher percentage of TB cases attributed to Bovis than the national average. As I mentioned, 4% in California versus 1 to 2% in the U.S. And unlike the TB case rate, which has been steadily decreasing in the last decade, our M. bovis rate has remained steady with no change really. The highest risk group in California, which is similar to that we see in the U.S., is for among Hispanic binational families and immunocompromised adults. And Bovis is associated with extrapulmonary disease, and when we looked at the new variables, it has a higher rate of death prior to treatment or completion. Switching gears for a little bit, now that you have a little bit of an understanding of who you're likely to see with M. bovis, how should we treat patients who present with M. bovis? It's a little bit different than the treatment for TB. We don't have a lot of direct data specifically talking about the treatment of M. bovis, but we can extrapolate from other studies that looked at alternative treatment regimens without using PZA, because bovis is usually PZA resistant. So these are studies looking a little bit further back. In 1975, the study was done by Fox. He looked at the efficacy of 9 months of therapy using INH and rifampin. And what they found was that this regimen was about 95% effective with a 1 to 2% relapse rate. Another study in 1984 looked at daily INH and rifampin for 1 month, followed by twice weekly INH and rifampin for 8 months. And they found a similar success rate of 95%. 2.8% failed to convert their sputum, and 2.1% relapsed. What do the CDC treatment guidelines say? Well, what they say suggest that if you have a PZA-resistant isolate or you cannot use PZA, then the regimen should be INH, rifampin, and ethambutol for 2 months, followed by INH and rifampin for 7 months, for a total duration of 9 months of therapy. Looking a little bit at how this regimen works in clinical setting, again, we don't have data specifically for M. bovis, but we do have a few examples of what's been used in the clinical setting. The first one is from San Francisco, published in 1988. At that time, they actually treated all of their TB patients with INH and rifampin daily for 9 months. So again, not specifically for M. bovis. But what they found was that there was a 1.5% failure rate among these cases, and that relapse rate was about 2% at 6 months, but then 0% at 12 months out. Dr. LeBouf mentioned that he was in San Diego and they published their experience with M. bovis cases in 2005. And what that paper suggests is that M. bovis patients were less likely to have EMB and PZA in their initial regimen, and the relapse rate that they found was about 1% and less than 1% for TB cases. So a little bit higher than TB cases for bovis cases compared to TB cases. So if you're a provider and you have a patient that has M. bovis, in addition to recognizing who they are and treating them, what else can you provide them with? Well, the first thing is that you should ask your patient if they consumed unpasteurized dairy products, how did they get infected with TB, with bovis specifically, and how frequently do they consume these products? It's likely, and the reason why you ask that, it's likely that the entire family is consuming the same products. So you may have one patient in front of you, but it's likely that the entire family is exposed to the same unpasteurized product. What you want to do is educate your patient about eating unpasteurized cheese. This graph or figure that I have on here, or picture that I have on here, shows you how to recognize what is pasteurized and unpasteurized. This word pasteurized milk will be on all of your cheese products, and that's what you want to educate your patients to look for. I'll have to say, it's not easy to find those words because it's in very small print, but if you take the time to show them how to look for it, your patients will be able to recognize it. For TB programs, the California Department of Health TB branch launched some new M. bovis variables in 2015. What happens is upon detection of an M. bovis case through genotyping results, the local program will get a notification and a supplemental M. bovis questionnaire that asks these two questions. Did the patient ever eat or drink raw unpasteurized dairy products made outside the U.S.? And if so, where were the dairy products made? Lastly, I just wanted to point out some resources for providers because sometimes this can be a challenging topic to discuss with your patients, but if you have limited time, you can access some of these resources. This is a recent flyer made by the Queso Fresco group that is based in San Diego after conducting several focus groups with pregnant women in San Diego. It's very simple. It just shows you where is the best place to get pasteurized dairy products and where not to get pasteurized dairy products. This one is specific for M. bovis in Queso Fresco, put out by the County of San Diego. It has a little bit more information about M. bovis and TB and dairy products, how is M. bovis transmitted and the symptoms and what individuals should do. These are all available on the internet for you to download, and I have the reference on these slides. There are several more CDC has on their website in M. bovis educational instructions for providers. It's a 2-page information sheet that also has a lot of data on it. But there are a lot of resources for providers, but these were the patient education materials that I thought would be helpful. And with that, I just want to acknowledge the people that put a lot of work into these slides, and I will pass it over to Dr. Jennifer Flood, who will talk about some cases.
Great, thank you, Dr. Shaw. And I know that you won't be able to stay for the question and answer period, so I think our other two faculty will try to field questions that are related to your session. But if there are some that are specific to material you presented, we may be sending those for follow-up later. So thank you so much. And Dr. Flood, if you're able to unmute your phone.
Yes, I'm unmuted. Can you hear me?
Perfect. Great. So it's my pleasure to introduce Dr. Flood, who will present several very interesting cases.
Well, I'd like to start with a case cluster that I think illustrates very nicely person-to-person transmission, as well as the consequences of the baseline drug resistance that we find in M. bovis. So this first patient is a middle-aged woman who is originally from Central American country and had been in the U.S. for over 15 years. She presented to a provider with abdominal pain and distension, and that provider tapped her peritoneal fluid and found it to be smear negative, but ultimately it grew on culture MTB complex. This was subsequently genotyped as M. bovis. Her chest x-ray at that initial presentation was normal, and she was started on treatment with INH, rifampin, and PZA. It wasn't particularly clear why ethambutol was not started. She then had drug susceptibility test results that returned and showed resistance to INH and PZA. She was sensitive to rifampin. She had significant adherence issues, and after 4 months, she declined all further therapy. Because she had disease that was restricted to the extrapulmonary site, there were no health officer orders issued. Then 2 years later, she presented again to the hospital with cough, weight loss, and fever. Her chest x-ray now showed bilateral, predominantly upper lobe infiltrates. She had positive sputum smears and molecular beacons showed INH and rifampin-related mutations. Her culture was positive for MTB complex with the same genotype as previous disease episode, revealing M. bovis, but now she is resistant to INH, PZA, and rifampin. So she acquired resistance to rifampin. She was retreated now with amikacin, an injectable, quinolone, ethambutol, ethionamide, and linezolid. So essentially, she was treated with second-line drugs for what is now MDR TB. Her culture converted after 2.5 months of treatment, and after 16 months, she again was done with treatment personally and refused further therapy, but has remained well to date. So what happened to her associates? This secondary case was patient B, who was middle-aged woman also, who had lived in a different county. She, too, was born in Central America, had been in the U.S. for over 15 years. She had a history of diabetes mellitus. After 3 years following patient A's diagnosis with MDR-TB, this patient, patient B, presented to a private clinic complaining of cough. She was treated with azithromycin and albuterol with the plan and recommendation to get a chest x-ray. However, she did not return for a chest x-ray until 6 months later, as her symptoms had not improved. Her chest x-ray at that time, 6 months after her presentation, showed a 6-centimeter left upper lobe cavity with surrounding infiltrate. The initial health department evaluation was notable for smear positive specimens ×3, gene expert positive ×2, and rifampin resistance detected. Her phenotypic drug susceptibility results later revealed resistance to INH, PZA, and rifampin, the similar pattern that we saw with patient A. Interviews were conducted by the health department, and those revealed that she had had extensive contact with patient A before that patient's MDR-TB diagnosis, so during that patient's infectious period, and she had often been spending 1 weekend a month with her. However, she hadn't been named as a contact to patient A at that initial contact investigation. This was her chest x-ray. You can see the cavity in the left upper lobe and extensive infiltrate. Now, this initial MDR-TB regimen that she was started on is shown here with capreomycin, moxifloxacin, ethambutol, linezolid, and cycloserine. She had culture conversion at 1 month into treatment, so a good response, and received her injectable until 6 months after culture conversion and remained on oral medications to complete her therapy. She had an identical genotype and drug resistance pattern to patient A. Now let's go on to the final case, who was a tertiary clinical case, so not culture confirmed, and this was patient C, who was the 16-year-old granddaughter and household contact of patient B. At initial contact investigation, this 16-year-old had a TST that was negative, but reported vague symptoms of cough without fever or weight loss and had a normal chest x-ray. On retesting 2 months later, she had a conversion of her skin test to nearly 20 millimeters, and now her chest x-ray shows a new small left upper lobe infiltrate. So I think everyone on the phone would see this as presenting with new, recently transmitted TB disease. This is her chest x-ray. Now, this young patient did have smears that were negative and cultures that were negative. She, as you saw, had very minimal disease on chest x-ray. However, she did have treatment for presumed MDR-TB, and her follow-up chest x-ray showed a slight clearing of the left upper lobe infiltrate. She had a shorter regimen duration recommended in view of the minimal disease and negative cultures. So just to summarize, while M. bovis we know is typically acquired when you consume raw dairy products that are unpasteurized, human-to-human transmission does occur. It's very often very difficult to document it. In this case, however, genotyping and the identical unusual resistance pattern confirm person-to-person spread. And while the first patient retrospectively did confirm consumption of raw dairy in her country of origin, the next two patients did not show consumption of raw dairy, and in fact, the patient who acquired resistance really that would have been hard to implicate, a raw dairy for patient 2 and 3. You heard from Neha Shah that diabetes and other conditions may predispose to M. bovis, and certainly this second patient had diabetes. The contact investigation, you can see, is important and is necessary for MTB, so you don't want to stop your contact investigation just because you hear about M. bovis, because M. bovis can be transmitted through the air. Now I'm going to move on to a slightly different topic, but a topic that comes up rarely but recurrently every year to many of us in terms of questions. We don't see BCG-itis, but when we hear about it, it's often surrounded with a lot of mystery. So I'm going to try to present a case and give you some information about BCG-itis. So BCG, you heard, is derived from an attenuated strain of M. bovis. And while it was first used in humans nearly 100 years ago, like most of our tools in TB, it continues to be widely used around the world to prevent the serious consequences, particularly disseminated disease and meningitis in young infants and children. So that's its primary purpose, where TB is very endemic and rampant and many children are infected. This helps prevent those consequences that are devastating in young children. In the USA, it is seldom used to prevent TB, but it does have a common use for bladder installation as immunotherapy when someone is diagnosed with superficial bladder cancer. So I'm going to describe a patient, patient D, who developed complications of BCG bladder installation. He was a 64-year-old who was U.S. born and had a history of severe rheumatoid arthritis as well as bladder cancer. He was being treated for pulmonary Pseudomonas infection with a persistent productive cough, but then was found to have multiple pulmonary nodules that were increasing in number and size with a new right lower lobe cavitary consolidation with effusion. The initial concern was primary versus metastatic cancer, but the biopsies were negative for cancer. Sputum was ordered. Someone did think about TB and ordered sputum for AFB, and this was kind of a back thought, but nevertheless a thought to cover the bases. His QFT was negative, but the specimen for AFB, although smeared negative, grew after 7 weeks, and the positive culture showed M. bovis BCG strain by HPLC. So let's look at the timeline. In 2001, this patient began monthly treatment with Remicade for severe rheumatoid arthritis. So we know that's a potent immunosuppressant. and actually can promote MTB progression. In 2004, he was diagnosed with bladder cancer. So he initially was immunosuppressed, then was diagnosed with bladder cancer. And so as you would want, that immunosuppressant was held during his treatment for bladder cancer. He was treated with resection and BCG bladder flushes times 3. So these were monthly. And after 3 months, the infliximab was restarted. In 2007, so almost 3 years later, is when his first abnormal chest x-ray was noted. In 2009, pulmonary BCG disease was diagnosed, and again, his immunosuppressant was stopped. So like everything we know about TB, this was a rather slow story and progression. Treatment with INH, rifampin, and EMB was begun, as you heard previously, because this was a mono-PCA-resistant isolate. The patient was adherent to treatment and was treated for 9 months total. And this patient illustrates the complete resolution of pulmonary symptoms and chest x-ray changes. So not only is M. bovis treatable, but BCG is treatable when it disseminates. So what we know about disseminated BCG is that we see it after the use of BCG for bladder cancer, and we don't have good data on frequency. I want to know, and search the literature, how common is it? If I had to get BCG for bladder cancer, what would my physician tell me about the frequency of this complication? It's very, very difficult to find. And because we don't do surveillance on this particular entity, it's not reportable on your case report, your nationally notifiable case report. We don't have readily available statistics, unfortunately, so I can't give you the frequency. I do know that I hear about it about once a year in California, so it probably occurs much more frequently, but I don't have a good sense of how often bladder cancer is being treated in this way. Anecdotally, we have been consulted on numerous cases of BCG isolated from distal sites, joints, CSF, blood, etc. So not only can it disseminate to the lungs, but just like other MTB complex organisms all over the body. There are no specific guidelines, but we have recommended treatment of this entity, BCG-itis, with 2 to 3 drugs, like for M. bovis, INH, and rifampin, plus or minus ethambutol for 9 months, with good success. So I just wanted to, end with the statement that, while we're very focused on airborne transmission of Mycobacterium tuberculosis, we do have to now pay attention that there's this other entity that is M. bovis, either communicated through ingestion of unpasteurized dairy or through the air, and also this much more rare entity of BCG that's disseminated from bladder installation. And, as our cases recede, we tend to hear more about these more unusual circumstances. As Neha mentioned, though, M. bovis, I would say, is not rare when we look at the fraction, 4 to 6% of our cases being M. bovis, and it's probably higher because a lot of our child cases are culture negative. It's something that we can pay attention to. It's actually something we can do something about, particularly working with our Mexican counterparts around pasteurization in dairy cattle. So I will end there. Thank you very much.
Thank you, Dr. Flood. Those are really interesting, I think good teaching points for us as well. So we are ahead of schedule, just giving us more time for fielding questions. So I'm going to open the line for questions to be fielded. And Jenny, can I check with you? Do we need to do any functions with the phone, or just if folks have a question, just press *6. And I wanted to maybe start by saying this webinar is brought to you because of an application for an on-demand webinar from LA County for this topic. So if LA County has some specific questions for our faculty, maybe we could start with you. Is Brian?
Are there any questions?
Okay, we can't. There you go.
Yeah, thank you so much. That was an excellent presentation. Thank you for Dr. Lebu, Shaw, and Flood. I had 3 questions related to diagnostics for M. bovis. Number 1, you mentioned that M. bovis is almost universally PZA resistant. The question would be, if you see a MTB complex that's PZA monoresistant, does that mean that it's M. bovis, or does that depend on what part of the world they're from? Number 2, regarding genotyping, using that to identify M. bovis, could you maybe go over the specifics of how exactly to identify M. bovis based on the Spiligo-Miriu results? And number 3, M. bovis BCG, in your case presentation, Dr. Flood, you mentioned that it was identified through HPLC. So I'm assuming that HPLC can identify M. bovis BCG?
So in terms of the first question about PZA monoresistance, if you have a specimen that's PZA monoresistant, it does not mean it's M. bovis. There are strains of M. tuberculosis that are PZA monoresistant. I think the likelihood will depend on what the characteristics of the patient. So if you have a patient who was born and raised in Mexico and crosses the border frequency and eats unpasteurized cheese, then it's probably really likely it's M. bovis. If they don't have any of those characteristics, then it's probably more likely it's just mono PZA-resistant M. tuberculosis. But the only way you can tell is by doing additional testing. The specific patterns of M. bovis versus M. tuberculosis with genotyping, I can tell you that I'm not the lab expert, so our lab people could tell you the exact specific sequences or repeats or missing patterns that are diagnostic. And so off the top of my head, I don't know. What I can tell you, as I remember, with one thing about spiligotyping is, and also with RFLP, is that you get very few bands with M. bovis. And so that's one reason why RFLP, for example, is not very helpful if you're looking at matching strains for M. bovis. But I have to ask the lab people to give the actual specifics of which spiligotyping and Miriu patterns are consistent with M. bovis. And what you had also a question about HPLC. Yeah, HPLC can be used to identify BCG, and HPLC can be used to speciate MTB complex, and also can be used to identify various species of non-tuberculous mycobacteria. So it is an alternative method that can be used for species identification.
Thank you very much.
Are there any other questions you're with a group there in LA, is that right?
Yes, we have about 68, 70.
Let me just add that when you see mono-PZA resistance in an individual diagnosed with TB, it has a fairly high sensitivity and specificity for M. bovis, but we noted when we looked at the Asian population, the specificity drops. So the pretest probability is lower, and so that's just something clinically that will help you. You see a young Hispanic person with mono-PZA, I think you can presume that that is M. bovis. If you see an Asian person, then you want to follow up a little more closely.
Okay, thank you. We have some other questions that are coming in online, and just a reminder, there is a Q&A box in the bottom left-hand corner of your screen. If you could post your questions there, then we can pull them out easily. We can't pull them out as easily in the chat box. So there is a question from one of the participants. Are you seeing any Mycobacterium bovis infection in immigrants from African countries? So I guess to either of our two faculty.
Yeah, I don't recall in our study whether there were any patients from Africa. I can tell you that if there were, they were very uncommon. They were overwhelmingly from Mexico or Central America or U.S. born of Hispanic descent. There were very few people. I mean, it's no question that that there's M. bovis, as I showed, in cattle in those countries. So I'm sure it happens, but we haven't, at least nationally, seen a lot of that in the U.S. There is another species of the MTB complex, M. africanum, which comes from Africa. That's not related to cattle, but we do see some of that in patients from Africa.
Okay, and there's another question related to transmission to household pets. Have you had any case reports of Mycobacterium bovis in any household pets or pets having to be tested?
I have heard of one incident, and as I recall, it was cats. Cats, based on consultation I had with an expert in M. bovis in animals, he told me that, in fact, cats are quite susceptible to tuberculosis in general. That's the only one that I am aware of.
And there was a nice article from, I think it was Ireland, around cats with M. bovis, but we have not had any instances of pet-related M. bovis disease that we've been able to identify in California, though cats are quite common.
Okay, great. Thank you. Interesting. There's a question about reporting. Why isn't disseminated BCG reportable on the RVCT?
Basically, when we discussed that, what we decided was because it's really an iatrogenic complication of a therapy. It really wasn't the same as a disease being naturally transmitted from person to person or from animal to person.
And I think the other reason is it's simply not contagious. It's attenuated and it affects the individual, but it's not contagious from person to person, so it's not really deemed a public health risk in the same way that M. bovis and MTB are.
Yeah, I mean, as far as we can, I'm not aware of any, where you've had even the people, people do get pulmonary disease and they can have positive smears, but I've not heard of or seen secondary cases of BCG.
Okay, thank you. Is there maybe I'll just check any callers on the line that have a question for either of our two faculty?
I have one. Is pyrosequencing then routinely suggested for M. bovis in order to rule out INH resistance?
So I don't, again, I don't recall what the percentage in the U.S., but when we looked at this in San Diego, there was basically the amount of INH resistance was pretty much the same in M. bovis as it was in M. tuberculosis, and the amount of MDR was similar. So, which actually may be somewhat surprising if most of it comes from eating contaminated dairy products, which you wouldn't expect, but because there is person-to-person transmission and people get treated, we think that's why you see it. But it doesn't, I don't, in all the data I've seen, I don't recall it being more common. I've seen it being on the same order of, so I would say, you approach it the same way you would for a case of M. tuberculosis.
And Bob, the other factor is that once you know that you have M. bovis or mono-PCA, you already have your INH and rifampin results back typically.
Thank you.
Okay, I have another question from one of the participants. It's an online question, and it's to you, Dr. Flood. In your case presentations, patient A. What do you think is the origin of her INH resistance? Was it from exposure to a cow or through human transmission? Do you have any speculation on that?
I think that's a great question. You know, I think what Dr. LeBoux just mentioned is that typically, if the naturally occurring M. bovis strains are mainly mono-PZA resistant, then you would think perhaps she did get it from another human if she also had INH resistance, unless there was a practice of feeding INH to the cows. So, or she could have taken INH at some point. So it's a mystery.
Okay, thank you. We're also trying to, oh, here we go. Question from Richard. We have an elderly patient with Mycobacterium bovis, BCG, of an infected hip after 2 total hip arthroplasty. The orthopedic surgeon is asking how long he has to wait after starting TB medication to do a 3rd hip replacement. Do you have any advice?
Yeah, well, I mean, for generally at CDC, we don't give individual patient advice over the phone based on limited information. So I don't think it's fair for us to do that.
So we would advise this question to be posted to our warm line, and we could get a clinician to answer. Okay. Are there another?
And I think it's fair to say that you know, it's the arthroplasty is probably not an emergency procedure. So once the person has clinically improved, and if there's any chance to culture, to document culture conversion, once there's been a lot of clinical improvement, if it was necessary to do it, then that would be the time. But otherwise, you'd like to complete therapy if the person can wait 9 months. But there's not a hard and fast rule on this.
Okay, thank you. Another question coming from LA. Can you give some recommendations for contact investigation among extrapulmonary M. bovis due to foodborne transmission? So,
our recommendations have generally been if it's pulmonary disease, if it's M. bovis, you treat it just like it's M. tuberculosis, because Jenny provided a specific example, and there's plenty of reports in the literature of airborne person-to-person transmission. So if it's pulmonary disease, then you would do a contact investigation just as you would do for M. tuberculosis. And also, when I was in San Diego, we did a study looking at comparing smear-positive M. bovis and M. tuberculosis and looking at contacts and skin test conversion. And in fact, the skin test conversion was fairly similar. So another suggestion that, yes, person-to-person transmission occurs and you should do contact investigations. But if it's strictly extrapulmonary, then there really is not a risk of transmission, and we would not recommend a contact investigation. Now, the one thing I would caveat there is some people call, if you have vocal cord disease or something, extrapulmonary, although it's probably really unusual to have isolated vocal cord disease, because most people think that the reason why people get vocal cord disease is because they have extensive pulmonary disease and they're coughing so much that they actually infect their vocal cords that way. But if it's not, if it's a type of disease that for M. tuberculosis, pulmonary, vocal cord, the type of disease where you would do a contact investigation, you do the same thing for M. bovis. But also, if it's extrapulmonary disease where you typically wouldn't do a contact investigation because there really isn't a risk of transmission, then there's no reason to do that for M. bovis. I think the one thing that Jenny brought up, though, about educating the family, because it's likely that if the person you're talking to who's got the disease got it from eating unpasteurized dairy products, it's likely other family members are doing it, and probably need to be advised about that practice.
Okay, thank you. We have a couple questions that are related to progression from infection to disease in both immunocompetent or immunocompromised patients. Is there any data related to how quickly an individual might progress from infection to disease?
I'm not aware of,
I think that
but
we don't have any data to suggest that it's very different from M. tuberculosis. Um, Certainly you saw in some of the cases that were immune suppressed, that that same kind of longer tempo can occur even under the conditions of an attenuated strain like BCG and then Remicade. So we also have many instances in where someone really, the only opportunity they had to ingest raw dairy was when they were a child, and then in their 40s when they developed HIV infection, developed disseminated bovis. So I think it can be harbored in your body just like other strains of M. tuberculosis and activate, but in the most immune compromised, it can be a shorter time period.
yeah, I would agree with that. I don't think we have really good data on it, but observationally and anecdotally, it seems to be similar to M. tuberculosis in the way that Jenny describes. The other thing about potential for reactivation many years later is occasionally seeing cases in U.S.-born people who are elderly and likely were exposed many years ago when there may have been actually TB in cattle on the farm where they lived. I mean, that you occasionally see that. So I think everything that we see tells us that it's probably similar to M. tuberculosis, but I don't think there's actual clearly published data that can prove it.
Okay, thank you. I've got a question from Charlie Crane. He says in Great Britain he's learned of intensive efforts to culling wild badgers to reduce transmission of M. bovis between distant herds of cattle. What role do you think intermediary hosts play in the epidemiology of M. bovis in the wild?
So probably the two best examples are the one you just mentioned, which is that England has the problem with badgers, which are actually different from North American badgers. So and North American badgers are not as susceptible, so we don't see that problem in the United States. But it has been an ongoing major problem, costly problem in England. And they've worked, and there's a great controversy about culling the badgers. There are many people who like wildlife and don't want to see badgers killed, but how successful it is, I think, so far it doesn't seem to be. And the same issue in the United States has occurred in Michigan related to their deer herds. And they've made great efforts in Michigan, and I think things have improved, but they certainly have not eradicated the disease, and so they continue to have infections, transmission occur from deer reservoirs to the cattle in Michigan. It's really once it gets into a wildlife population and it's sustained, it appears really, really difficult to get rid of it, and it means that the cattle will be at risk, and it's a persistent problem.
Okay, thank you. There's lots of great questions, so I'm trying to check all of the different areas, but let me check quickly online if we have any callers online that have a question that you've been waiting. Okay, how about, there's a question from the TB control branch. How useful are current genotyping methods for differentiating different strains of Mycobacterium bovis?
I think that's a somewhat open question. They probably are not quite as good as they are for M. tuberculosis. In fact, the USDA, granted that they have to deal with many fewer isolates than we do, but they've gone to whole genome sequencing as their routine method of genotyping, and so it's whole genome. There's no question that if you do that, you get more discrimination and it's better. So I think I think we haven't probably studied it carefully enough in humans to know for sure, but whole genome sequencing is better, just as it is in M. tuberculosis. The discriminatory power is better. My gut feeling is probably for M. bovis, our methods are probably a little better for M. tuberculosis than for M. bovis, but I don't know that we could prove that.
Okay, thank you. We have a question, let's see, about experience. I don't know if you can answer this or not. So this is a question related to encountering disease that is INH resistant rather than PZA resistance following BCG installation. It looks like there may have been some reports, some published data related to this, related to the Sanofi BCG strain. I don't know, Phil, if you know anything about this question.
Not aware of that. I mean, it would. I don't. So it would. You know, certainly anything is possible because INH mutations occur spontaneously, but it's generally they have to be selected out under the pressure of treatment with INH. So if you know, why a strain that was being developed for vaccine, why the likelihood that you would actually get sustained INH resistance would seem low, although it's I said not impossible. But I'm not really aware of the details of that instance.
Okay, well, thanks. Thanks for what you were able to share. This is a three-part question from Kathy. Question 1, were there any cases of M. bovis detected by screening school children? So maybe just we'll start with that question.
I'll ask Jennifer for California. In the you know, we don't track, our surveillance system doesn't track detection through school screening, so we wouldn't have that information.
And at the state level, I would say the same thing. We don't track that particular, you know, specific mode of screening. We have very few cases that are detected because of school screening, and we actually, you know, most counties no longer, you know, they're screening and then testing that is following, but there's not really universal school-related screening in terms of young children. Colleges, on the other hand, are ramping up to do school screening universally with a risk assessment followed by testing. So the short answer is no, I'm not aware of any cases that have been detected from that method.
Okay, and kind of related to screening, what do you expect the IGRA result to be for M. bovis, for someone infected with M. bovis?
Since the antigens that are used are in M. bovis that causes disease, we would expect the results to be positive. The antigens were selected for that test based on specifically on the BCG strain. That BCG does not have those antigens. So BCG should not be positive, but M. bovis that's not BCG should be positive if they're infected.
Okay, thank you. Is there any data regarding the risk of old unpasteurized cheese spreading Mycobacterium bovis disease as opposed to fresh unpasteurized cheese? Not really. I guess that would be hard to know.
Yeah, I don't think I could answer that question definitively. I know, at least in talking to some of the people who like FDA and so forth, that they, you know, with the age, when cheeses are specific, you talk about aged cheeses and cheeses that are specifically aged, as opposed to fresh cheese. And I don't know whether, there's a difference between fresh cheese that just ages on its own or others, I think, commercially aged cheeses. But I think the commercially aged cheeses, from what I understand from the FDA, it is less likely that the organisms would survive, and that most of them, this goes with other infections too, that they're typically associated with fresh cheese.
Okay, thank you. This question is from Kathy. She is going to be doing targeted testing with Hispanic farm workers in the near future, and she's wondering what specific questions should she make sure to ask in the initial screening regarding both Mycobacterium tuberculosis and M. bovis. Most of the workers are from Ecuador. Any advice?
Well, I think the first thing is that being from Ecuador, their risk obviously of TB is higher than if they're U.S.-born persons. I mean, I don't know what the details of the screening program are, but if you're interested in what depends on what your goals are. I mean, if you're interested in what their risk factors for M. tuberculosis or M. bovis just being infected, probably number one on their list is that they're, in terms of M. tuberculosis and M. bovis, is they're from outside the United States in a country that certainly has a higher incidence of M. tuberculosis and probably has a higher incidence of M. bovis. But specifically for M. tuberculosis is, have you ever been around anyone for any period of time that you know has had tuberculosis, because that would be the major risk factor for them becoming infected. For in addition, for M. bovis, it would be do you eat dairy products that are fresh and not pasteurized? Do you drink milk that's not, or have you had a history of drinking milk that's not pasteurized? And then the other factors that you want to consider, depending on what the goal of your program is if, then factors that make people more likely to progress, if they are infected, more likely to progress from infection to disease, such as HIV or risk for HIV, underlying conditions that cause immunosuppression, like diabetes or being on immunosuppressive drugs, having had a transplant, etc. I mean, those are typically the types of questions we ask people when we're screening for tuberculosis.
Okay, thank you. A question regarding testing: should pyrosequencing be done routinely on M. bovis to assure that there's no INH resistance?
I think we answered that question earlier, that basically we don't have any data to suggest that INH resistance is more common with M. bovis, but from the data that exists, it's probably comparable. So you would approach an M. bovis patient in terms of approach for detection of drug resistance the same way you would for an M. tuberculosis patient. And as Jenny mentioned earlier, probably by the time you're thinking, or know, if you know it's M. bovis, it's because you've already gotten some drug susceptibility results back, like the PZA test, and you would already know the INH results. Or genotyping's already been done, which means you probably already have drug susceptibility testing results. So I don't think there would be a specific reason to recommend it just for M. bovis.
Let me just add to an earlier question. I noticed that Jeff Driscoll is on the line and is making the remark that INH resistance in some strains of BCG is well documented, and that's really important and pertinent to a question that was asked earlier, that it looks like the literature does show some kind of naturally occurring, which you might expect, INH resistant strains. So that's a good thing to know. So thank you, Jeff.
Great, thank you. A question about if family members of an extrapulmonary case also ate unpasteurized dairy products, should they be screened for LTBI and treated if positive?
Yeah, I mean, we would generally do that. In San Diego, certainly if we knew a family that had first, screen them in terms of asking questions about, are they sick, do they have disease, make sure they don't have disease. You can test them for LTBI, and if you're sure they don't have TB disease and they're positive on the LTBI testing, then you would treat them for LTBI. And generally, even though this has never been studied, we have made the assumption that drugs which are effective for LTBI treatment in M. tuberculosis we would use for M. bovis in the same way, unless there was some reason to think, based on the initial case, the index case, that index case had some drug resistance. So if you know the index case is susceptible to INH, then you would use INH in the other family members who were either skin test or IgRA positive, or you could use 3-HP if you knew the index case was susceptible to INH and rifampin. But generally, we have, even though I'm not aware that anyone's done any kind of study proving that you can prevent M. bovis by the treatment of presumed M. bovis LTBI, we have made the extrapolation that what works for MTB should work for M. bovis in the case of latent infection.
You know, another kind of take-home point related to that question is, you know, a goal of a contact investigation surrounding, let's say, an extrapulmonary M. bovis case might be, you know, if you have a mother who has extrapulmonary M. bovis, she may have children that are consuming raw dairy, and so you'd want to intervene on that behavior and provide some education, as Neha had described, to kind of prevent future cases. So that's one intervention that we tend to not think about around our typical CI. So M. bovis, you know, should prompt one to kind of look into the social network that might be consuming raw dairy, and also, let's say that person's immune compromised and they get treated for their M. bovis disease. You know, they can certainly eat raw dairy again and develop disease again. So you'd want to also make sure that they're not going to continue to consume unpasteurized dairy products.
Okay, well, thank you. These have been really great questions, but sadly we've come to the end of our time. So at this time, I'd like to thank our presenters, Dr. Phil LeBoux, Dr. Neha Shah, and Dr. Jennifer Flood. Thank you so much for these really interesting sessions. And at this time, I'm going to pass back to our program manager, Jeannie Fong, for closing comments.
Okay, we will leave the Q&A window open for a few more minutes. If you have any more questions, please enter them in the Q&A panel. We will forward these questions to the faculty, and we will compile the responses and post them as a FAQ along with the recorded webinar in a few weeks. This concludes today's webinar, but before you log off, we would like to remind you to complete your individual online Qualtrics evaluation. They should have already been sent to your email addresses. We value your feedback on our webinar. Thank you for your interest and participation in today's webinar.